the Ruxolitinib and decitabine study that we conducted at MD Anderson was a phase 1-2 study of this combination in patients with post-MPN AML. And this is now published as a letter in Leukemia 2020. Post-MPN AML is frankly an absolutely devastating diagnosis, probably the worst of all clinical subtypes of AML. And important to mention is that although AML has seen about 8 drug approvals in the last 2 or 3 years, several of these, the ones that were tested in the frontline setting, consciously avoided enrolling patients with post-MPN AML, again, because that is a particularly poor prognosis subgroup. So it's important to note that there's really been no advances for those patients. So why Ruxolitinib and decitabine? Well, we and our colleagues at in New York, the MPN Research Consortium have both been independently studying this combination for some time. It's a synergistic one in the laboratory, so that's for starters. And then just logically, you want to shut down the JAK-STAT pathway, which we know is universally activated in MPNs and presumably is also in the blast phase. And then decitabine, which is a well-tolerated, easy to deliver, tried and tested drug for AML in general, particularly in the older/unfit population, been around for 15, 16 years now. So this was both a synergism-driven and a logical combination of the two drugs. Now, our two groups ran our phase 1s, and then in our phase 2s, we actually ran we conducted the trials with different strategies. So I'll just mention that. Our group, in our paper, as we have said, we found the maximum tolerated dose of the combination to be the usual 20 milligram per meter square per day for 5 days every cycle for decitabine. And then for Ruxolitinib, we actually found a very high dose, 50 milligram twice a day, as the recommended phase 2 dose. We had no dose-limiting toxicities in phase 1. So we took that relatively aggressive dose of Rux forward with the decitabine in the phase 2. Our colleagues in the MPN-RC actually adopted a different approach in their phase 2, going with a much lower dose of Rux, which they found was easier to deliver and which people could stay on for longer periods of time in their experience. Regardless, and sadly, from a survival standpoint, neither of our groups was able to show anything really too exciting or to something to write home about. We had about a 7-month median survival, and so did they. These are completely independent studies, and like I said, slightly different ways of giving Ruxolitinib and decitabine. But again, this is an easy regimen on patients. It's easy to deliver outpatient, tolerated well, and importantly, we did see some, complete remissions, complete remission with incomplete count recovery. A couple of patients were able to go to transplant, which is really important because the only thing that has ever worked in this disease, in post-MPN AML, is to get your patient into a complete remission and then take them to transplant. So while that was not frequent, we were able to take 2 patients to transplant, I think, in our cohort of 29. Our median survival, like I said, was about 7 months. Again, the 2 studies, the MPN-RC study was published, at least the phase 1 in Blood Advances in 2018, and ours kind of a composite paper of describing our phase 1 and 2 results this year in leukemia. Very similar survival. So a lot needs to be done, remains to be done in this field, unfortunately.